Hello guys, I'm recording this so that you can study for the midterm. Sometimes we don't get enough time after the oncology lecture to get this in, and so the good news is I hope you can review this lecture more than once since it's recorded, and that'll help you do better on the midterm. As always, please review the objectives to help you because the study questions, the test questions are often based right off of the outcomes and should refer directly to the outcomes. For the test, you should review the anatomy and physiology of the hematology section, and that includes the red blood cells, the white blood cells, and the platelets. I know you have gone over this before in previous classes, and have also gone over this for your med-surg class, so I won't spend too much time on this, but as you know, the red blood cells, the main function is oxygen carrying capacity and also removal of CO2. So that's very important, and most of your problems with oxygenation and CO2, you will want to troubleshoot those with the blood. White blood cells, of course, you will be troubleshooting problems with the white blood cells, and that includes all the different components of white blood cells, and platelets generally, if there's a problem with platelets, you'll troubleshoot that as well. The components of the white blood cells can usually be seen when you are looking at a smear of the white blood cells under a microscope, and you can see the shape of the interior of the white blood cells, and that's how they're categorized in the lab. So as you know, you start off with the immature white blood cells, and then they differentiate from there. So they count them manually, or now they can be counted more quickly with the aid of a computer, and that tells them how many of different type of white blood cells they have, and based on those numbers they know what kind of infection they're dealing with, if they're dealing with a viral illness, a bacterial illness, or sometimes the numbers can tell them if they're dealing with an allergy, or maybe a fungal illness, or some other kind of illness. Also, if certain numbers of the white blood cells are depleted, that tells them a lot. If they have a large number of immature white blood cells pushed out, that means that they're very ill, because they're reduced to only having immature white blood cells. That's called a left shift, and that's very important because it means that the patient is much sicker than a patient that has plenty of white blood cells left to use. Pediatric differences from adults are that, first of all, the normal values in the CBCs are different for pediatrics, so you will not need to memorize them, but you should know that you have to look them up every single time to check and see if they're in normal range for children, and they're different by age. Hematopoiesis is the process of making red blood cells and white blood cells. So that's a little bit slower in children, especially the younger they are. And so it's more severe if they have an illness where they're low on red blood cells. And so you should know also that white blood cells are the highest at birth because they have an influx of white blood cells from the mother across the placenta at birth, but after the cord is clamped, they have a lag time before they're making their own white blood cells, and so they're at most risk because of an immature immune system and an immature ability to make their own white blood cells at birth. And so that's why one of the reasons that we have such a concern for infants getting exposed to illness. And then also know that the platelet levels in newborns is lower than in older children and in adults, because as you know, platelets are developed from the destruction of red blood cells. So if they're not making red blood cells as as fast as older kids and adults, then they're also not making platelets as fast as older kids and adults. So that's all very important to know. I don't usually test on this, but it's important to have a general knowledge of the function of the white blood cells and what an elevation or a lowering in each of these can mean. And so neutrophils, of course, are important in phagocytosis. And phagocytosis can be any foreign body that the white blood cells find in the system. Basophils are involved in inflammatory reactions. Eosinophils are more indicated in allergic reactions. Monocytes and macrophages are more involved in antigen processing, and lymphocytes are more involved in humoral immunity. Also T cell immunity. So make sure that you kind of have an idea of that, review that. It'll help you as you go along in nursing. Now, here's the point where you really need to dial in for the midterm. Most of the test questions, a large majority of them are going to be on these different disease processes. So iron deficiency anemia is one that's one of the more common things that you'll see in children in the pediatric population. It's caused by inadequate iron intake. And but it can also be caused by blood loss or malabsorption problems. So you might see that in some GI disturbances, or also periods of rapid growth because the iron needs increase, but the child's absorption of iron hasn't increased to match. And so signs of this would be pallor, fatigue, and irritability. And the treatment would be supplementing with iron. And it's always better to get iron sources from a natural dietary source. Always, always, always. However, if we do supplement children with iron, you should know that iron tablets and iron drops are more for infants, and they do have formula that is supplemented with iron. But if they get iron drops, it's green and it tastes nasty, and it can stain your teeth. So if kids have teeth, we want them to avoid, getting it on the teeth. If kids have teeth, generally we switch them to the tablets because they can swallow it and get it past the teeth. And if it's in droplet form, then we try to teach parents to get it past the mouth, get the drops past where they can swallow it in the back of the throat and not taste it. It tends to taste really bad. We don't want them to put it in the baby's bottle and mix it with all the formula because it tends to make it so they spit out and refuse the rest of the formula. And then other things that are considerations with that is that it turns the stools green and can cause constipation and things of that nature. So natural sources, make sure you review natural dietary sources of iron. As far as nursing care goes, you would want to screen kids for this, especially in age groups where they are growing rapidly. So as a school nurse, for example, you would want to screen for this, especially during middle school and high school years. And you would educate the parents. So one question I would ask during those age groups is, have you noticed if the child has syncopal episodes that can happen during periods of rapid growth? Again, pallor or signs of extreme fatigue. Ensure that they're getting iron in their diet. So that usually means meat, but you can get iron from vegetable sources. And then once we've identified an iron deficiency, we want to make sure that they're compliant with taking their iron supplements. Now there's normocytic anemias. This means that there's an increased destruction of red blood cells or a decrease in production of red blood cells. And the treatment depends on the cause. So for example, things that increase destruction or decrease production of red blood cells could be an underlying disease process, like maybe leukemia. So what we want to do is have some testing done to determine what that underlying cause is. And then once we identify that, we can go from there. Now, sickle cell anemia is a heavy focus on the midterm. A lot of the questions deal with sickle cell anemia. So the thing to know about sickle cell anemia is that it's an autosomal recessive disorder, of course, and it affects those of African descent and also Mediterranean descent more than those of other descents. And of course, you know of from other classes that you've had that it causes the red blood cells to become sickled in the presence of deoxygenation, generally. So the sickle shape of the cell results in that cell wanting to clot. And so as a result of that clot, it causes ischemia, obstructions, and organ damage around that clotting area. Common manifestations of sickle cell anemia are going to be infections, because if you have ischemia in a certain area, your body responds to that by starting an inflammatory process, and that draws infection to the area. You can also have clotting in the lungs, and that can cause impaired respiration. Also, any part of the body that has ischemia will be painful, and that causes shallow breathing. So when you're in pain, you tend to shallow breathe, and that leads to respiratory infections when you shallow breathe. There can also be microclots in the skin, and that will manifest as skin changes. So the skin can get dry, cold, and hard, and it can also have darkened areas where there's microclotting. There is more than one type of sickle cell disease. So sickle cell anemia type SS is the most common, and it does shorten your lifespan. So this is about 65% of people with sickle cell disease, and it shortens your lifespan to about 45 years of age. And this is why this is in the pediatric section, because the onset is from birth, and we want to teach kids how to manage it correctly to promote a longer life. The other type of sickle cell is type SC, and that one does have a longer lifespan. Lifespans are up to age 65, and this is only 25% of the cases. And then the remaining type are called thalassemia disease, which it's easy to forget that that's also a sickle cell type disease. So remember that. All right, one of the most important things to know about sickle cell disease is the things that are potentially life-threatening or can cause loss of life or limb. So vaso-occlusive crises are generally pain crises, and they're the most common type of event to happen in people with sickle cell. So what happens is they have a clotting event, and it can happen anywhere in the microcirculation, but it is precipitated by dehydration, temperature extremes, infections, localized hypoxia, emotional stress can cause it, and really it can be caused by changes in elevation. So people with sickle cell disease often don't live here in Reno, because being at this elevation that we're at is often too high for them. Being at our elevation can cause them to have a sickle cell crisis just being here. Or if they're here and they take a trip up to Tahoe, that can trigger it. Also, our temperature extremes that we have, it's too hot in the summer and it's too cold in the winter. So that can cause them to have sickle cell crises. But we do have students that come here to go to college at UNR, and they can be triggered during those times of the year. So when they do get sick, they can be triggered into a sickle cell crisis. Anytime they get a fever, they can have a sickle cell crisis. So it's extremely painful, and we often treat it with oxygen. That's helpful. We treat it with fluid boluses to try to help clear those micro clots by increasing the internal diameter of those microvasculature areas where the clots are occurring. We want to offer pain control to help them breathe easier, and that helps relieve some of that stress. Other manifestations are tissue engorgement, painful swelling over the joints, hands, and feet. Priapism is a medical emergency because they can get a clot in their penis if they're male. Severe abdominal pain is often associated with clotting around the intestines or possibly the spleen. And the severity is related to the degree of the infarction that they're experiencing. The infarctions can be reversed possibly with clot busters. Some of them may not be reversible or aren't reversed in time, and so that is when it's dangerous because parts of their body are going to be reabsorbed, and those can be parts of the body that, or they can become necrosed and die. So those can be parts of the body that they need. One of the most life-threatening crises that a sickle cell patient can have is a splenic sequestration. So when you have dead parts in dead cells in your body, your macrophages go into action to remove those, and then they absorb them into your lymphatic system, and your lymph system drains those into your spleen. Well, your spleen is really only as big as maybe a golf ball, and that can quickly become overwhelmed and distended. And first of all, when it becomes distended, that's painful, but it can also burst open. So if it bursts open, that's a medical emergency because you can leak massive amounts of lymph fluid into your body, and you can have a hypovolemic crisis from that and die. So there's profound anemia associated with that because you're also leaking blood, hypovolemia, and shock. It's a life-threatening emergency, and death can occur within a couple hours from that if it's not recognized and treated. And then finally, aplastic crisis, and this is usually triggered by a viral infection and depletion of folic acid. If you remember, from nutrition, folic acid is needed for making red blood cells. So if you have massive depletion of your red blood cells, generally what we do with these patients is that they come in periodically for blood transfusions. But if they don't get in for blood transfusions, they can be very depleted and that's why it's called anemia, right? Sickle cell anemia. They need to have folic acid to continue making their own red blood cells. It's very important that they continue to make their own red blood cells. And so they have a diminished red blood cell making capacity, and this signs include profound anemia, which is manifested as pallor and extreme fatigue, and it can be life-threatening, particularly if they're not getting frequent blood infusions. And frequent blood infusions are not always practical for people, so especially if they can't get to the hospital weekly for those transactions. So this can definitely be life-threatening. So those are the main points you need to know. And also think about things like genetic counseling, because if they are the age of reproduction, they may be concerned with whether or not they're going to pass this on to their children. That could be important. As I said earlier, thalassemia is also a type of sickle cell. This one also causes fragile hemoglobin, but it doesn't cause the sickling effect in the hemoglobin. It also mostly affects people of Mediterranean descent, and it does also cause severe anemia in people. And there's hemolysis of the blood. In this case, there's more deposits of the hemoglobin in the body, and the hemoglobin deposits tend to cause nodules in the skin and throughout the body. So you'll see those skin changes caused by the deposits, and also you'll see jaundice with when red blood cells break apart, you have the deposit of the bilirubin throughout the body. And that's true with sickle cell as well, that the bilirubin is spread throughout the body. So that can cause some mental mental status changes while there's an excess of that bilirubin, and that's true also for sickle cell. There's a little bit of fatigue, maybe some profound fatigue associated with that excess of bilirubin while they're clearing that. Manifestations of thalassemia are also pallor, fatigue, delayed growth. There's a higher susceptibility to fractures, congestive heart failure, and also splenomegaly, as there is also with sickle cell anemia. So hereditary spherocytosis is not on the final. So I'll just touch on it briefly. The inheritance pattern of hereditary spherocytosis is autosomal dominant in 80% of the cases. The clinical manifestation are mild jaundice, aplastic crisis. Aplastic crisis just means that there is a change in the shape of the cells, the red blood cells, and there is there are gallstones with this. So there is surgical intervention done to treat the gallstones often. They treat with weekly or daily red blood cell transfusions as is practical, and then daily folic acid. So aplastic anemia can be referring to a non-genetic disorder that can be seen in the general population. Anybody can have aplastic anemia. So if you see that in a patient, it just refers to a misshapen red blood cells or a reduction in red blood cell production. You can have pancytopenia, which pan refers to all the red blood cells reduction. This could be acquired or inherited. It's generally more prevalent in Asian children. They're at the greatest risk for having this. The clinical manifestations, you'll see anemia, thrombocytopenia, and neutropenia. After sickle cell, there's probably more questions on hemophilia. Is probably the second most test questions on the midterm. So hemophilia is also a genetic disease, and it's inherited. When we say it's sex-linked, that means that females carry it, but it's most often seen with symptoms in boys. So this is one of those interesting diseases because it played a really big part in European politics. So Queen Victoria was a carrier, and she had 9 children, I believe. And so her children intermarried into all the royal families at the time of Europe. And so all her female children married into the royal families and carried it silently. into those royal families. So I believe Russia, Germany, Greece, Italy, all these different countries ended up having hemophilia disorder in their next generation because of this. So it became really, this was a time when they didn't know about the genetic characteristics of hemophilia. So it really became, it became a, there was a leap in the understanding of the genetics at that time. Um, so hemophilia can be mild and very treatable to very severe, and it's predominantly presents as bleeding after an injury, and it can be a mild injury to severe injuries. So you can have internal bleeding that's not noticed. So suppose you would normally bruise, that bruising can be very, very extensive. Or it can be like from a nosebleed that should be mild, but in a patient with hemophilia, it's very, very extensive. So suppose you have a child that is just playing soccer, that child gets kicked on the leg. So they should have a normal bruise like a normal child would. Well, this child might have the entire leg turn purple. Or if they get kicked in the side, a normal child might have a bruise there. They would have possibly internal bleeding there that might cause them to need to be hospitalized. Joint bleeding. So this is very this is very painful. So if the thing with bleeding into a joint is it's a closed capsule. So if you bleed into a joint and you have a bleeding disorder, the bleeding doesn't stop until there's pressure in the joint to make it stop. So it just keeps bleeding until the joint pressure makes it stop, but it's painful. So to make that stop, the capsule can get distended and very painful. So the treatment would be to elevate it and apply ice, and then compression. So remember your RICE. The rest, ice, elevate, compress. Mnemonic, remember that in this case. That would be the treatment. I think that's on the test too. And then von Willebrand. So von Willebrand is a very similar disease to hemophilia. In this case, it's a lack of VWF factor. It's a lack of a clotting factor, and the amount or function, and it's part of the platelet adhesion. So symptoms are similar to hemophilia. They're not able to clot their blood. And then finally, I'll end on the most severe one. There's only one or two questions on this, I believe. But this is the most severe. And you'll get more of this in your next semester class. This is called DIC, or disseminated intravascular coagulation. And I experienced this so far once in my career. And so I like to tell students that the first time I experienced this, I recognized it immediately from the textbook because it's very distinctive. My patient went from having bright red blood and a lot of blood to having watery, Kool-Aid looking blood, very thin Kool-Aid looking blood, watery blood. And so I want you to look at these little charts here. So this is the mortality rate here on the left in the vertical position. So from 0 to 2 hours, days, and this is their DIC score. So at the mortality rate rises from 20% at 0 hours or days to at 7 days, it's 70%. 7 days out, it's got a 70% mortality rate. So my patient that had this, she was postpartum and the doctor accidentally nicked an artery during a C-section. And she bled so much that she bled off the end of the bed, which I had never seen. And the dad was standing there holding the baby, and the lady had come out of the OR. She had a blood pressure of about 110 over 70 initially. And then I started to massage her fundus, and it seemed like a clot was coming out. So the doctor walked up like they normally would to congratulate the patient. And so the doctor was immediately present, and we started doing the normal things. We gave like hemabate and a cytotec and all the things you would normally do, but the lady kept bleeding. And like I said, the blood went off the bed, and then it got to where the blood kept going and it was out the door. And the husband was starting to look pale at this point, and so was I. And then when at one point the blood stopped coming, looking like blood, it started turning to looking like Kool-Aid. And I said to the doctor, I think this is DIC. And the doctor said, no, it's not. You can't diagnose DIC except by doing a D-dimer. And I knew it was DIC. So I insisted, doctor, I think we need to move this patient to the ICU. So she insisted that we had to have a D-dimer first. So D-dimers take about 15 minutes to do. So we had an emergency D-dimer done. In this period of time, the patient's blood pressure had dropped to 40 over 10, which is the lowest blood pressure I've ever seen. And then we moved the patient to the ICU, and she received 150 units of blood. And the only reason this patient didn't receive more than that was because we were on the island of Guam, and there was no more units of blood on the island. And that was it. There wasn't any more, and the patient was in a coma. So she was in a coma for 8 days, and we couldn't get her any more blood. So she survived, but she was very lucky. They had to take out her uterus in the ICU because they couldn't get her to an OR in time. So they had to open her up and take the uterus out. It was her first child, so she was never going to be able to have another child. And so that was my experience with DIC. And some of the take-home messages I learned from that is that the average amount of blood that patients receive when there's a DIC is much higher than 150 units. I've talked to nurses who say that they've given over 200 units of blood and more to patients in DIC. And the reason is because they go back and forth between with DIC, it's called disseminated intravascular coagulation because the whole body is clotting. So you could give something to make them not clot, but then they would continue bleeding. And so then you replace the blood, and then it would continue to leak because then you could give them something to make them not clot, then they would continue to bleed. So you go back and forth between trying to make them clot and not clot at the same time. And it's really a difficult thing to treat. They have several reasons. Several things can trigger DIC. It can be triggered by a hemorrhage, which is what happened in my patient. It can be triggered by clotting factor depletion, and that's really why a hemorrhage triggers it, because if the patient's bleeding and the body is trying to deal with a hemorrhage, it tries to clot, and that's why it runs out of clotting factors. Ischemia can also cause DIC. So if you have massive ischemia somewhere, the body tries to deal with that by issuing clotting factors. So clots can trigger it, and then also post-infection. So you can get it as a result of sepsis. Sepsis can trigger it. So people can come in DIC from a car accident. Lots of things can trigger it. So just know that if you're on a regular surgical unit and you suspect that your patient has this, they need to be in an ICU because you cannot handle this if you have 5 other patients. They need to be in an ICU setting. All right. Now this one is called idiopathic thrombocytopenia purpura. This is often confused with petechiae. The terms can be used interchangeably. Lots of things can cause petechiae, but this is associated with a particular disease process called ITP. It is more common in Caucasian children, and it often follows a viral infection. This particular disease process is caused by a autoimmune disease that's caused by destruction of platelets in the spleen. It's normally you would see something like this and you would think of bone marrow cancer, leukemia, but there's actually normal marrow production. So this is something we might think of, and we would test for leukemia. If we rule out leukemia, then we might think of the ITP. So the presentation of this is excessive bruising, petechiae, bleeding of the gums and the oral mucosa, bleeding in the urine, and bleeding in the stools. Now, hematopoietic stem cell transplantation is something that Professor Smith mentioned that her son got, and different patients get stem cell transplantation for different reasons, for different disease processes. It's just a procedure where you get a bone marrow transplant. So indications can be leukemia, aplastic anemia, and some kinds of immune deficiency syndromes. It can be autologous, which means you give the donation to yourself. And to do that, you generally have to give yourself the donation before you have a treatment that's is going to deplete your bone marrow. You can get an allogenic transplant from a matched donor or an isogenic donation from an identical twin. This isn't going to be on the test, but you should know it for NCLEX purposes and the ATI. To get the transplant, you have to have a human leukocyte antigen match. Usually, to get it, there's been destruction of the bone marrow, usually through chemotherapy or radiation. You can get an IV transfusion of donor marrow, and there's a high risk of infection and bleeding risk with this. So it's not a risk-free procedure. So in patients with pancytopenia, you want to limit or put them in reverse isolation. And this is usually cancer patients, but they could have pancytopenia for other reasons. You actually want to put them in sterile environments if possible, the room, like they're not supposed to have flowers delivered. Usually these are your severely ill cancer patients. Antibiotics and blood products are administered to try to help keep them as well as possible. They're often on TPN because they can't handle regular food, because if you think about it, food's not sterile. And then limit the effects of being isolated. When you're on isolation precautions, your mind suffers from the effects, and especially kids are most prone to the effects of being isolated socially. So we want to think about what the effects are on them mentally, and try to keep them socially active with their friends via the internet, however they can with their social group. We also want to look for graft versus host disease if they get blood transfusions and stem cells or marrow transplants and whatnot. So that can remember that those kind of reactions can happen days or weeks later after the transplant. So review that. And that's all that I have. So good luck on the test.